So I would like to call upon first speaker, none other than Dr. Pramod BHENDE, who is heading one of the foremost and one of the most important center which has trained most of the people for the country. He is chief of now Retina there, Shankar Netralaya, Chennai, down south. So we are really privileged to have him over here, and he has a lot of experience on pediatric retinal detachment. Dr. Pramod, please.
Thank you very much, sir. Thank you, and thank you at the outset. Thanks, APA and AIOS for having me here. And good morning, everybody. And I think thank you. It's the last day. We still have a few people here. Thank you so much for being here. So, coming back to the talk, basically, when you deal with pediatric retinal detachment, just quick overview here I'm going to give you. So, most important to find the cause. So, basically, the commonest being a post-trauma, high myopia, and very, very important thing what I'm trying to highlight here is previously badly done ophthalmic surgery is a major component, almost 20 to 51% of IM. I'm dealing here mostly with a regmatinous component, not exudative tractional component. I'm not adding up here. And when you look at a congenital disorder, that's a big chunk when you deal with a pediatric retinal detachment. So this is one of the pictures showing bilateral involvement. Most of these eyes, because being a congenital disorder, chances are there, bilateral involvement is there. The Stickler syndrome, having one eye, having a large tear and detachment. You look at the vitreous, suppose here, look well like vitreous here, and other eye having a lattice degeneration. So coming to anesthesia, is an integral part of when you're dealing with the pediatric eyes, and you need to have a lot of systemic disorder, and exceptionally trained anesthesia team is without them practically you cannot handle these cases. So I always thank my anesthesia team for being with me always. So preoperative consideration and look at into, usually you have an inability to determine preoperative vision. They are difficult time consuming examinations, and invariably these eyes need examination under anesthesia to decide your plan, and finding on examination may alter your surgical plan, and you need to counsel parents for the same. Sequential bilateral surgery, yes, can be done, but generally as a protocol, we keep it an exceptional situation where anesthetists feel that second anesthesia cannot be given. So it's important to understand pediatric anatomy here. So these are narrow palpebral fissure, reduced axial length, cornea is smaller, though anterior segment is almost 80% of adult surface area, but posterior segment is just 20%. Sclera is extremely thin, so angle incision or two-step incision usually invariably practically not possible, and low scleral rigidity, so invariably most of these eye need to suture the sclerotomies. Lens is softer but more spherical, so there's a high risk of lens touch. And pars plaqueta, though is normal, but pars plana is not developed, so most of the surgery are doing through pars plaqueta. So coming to scleral buckling, this is a typical case of clear media, localized detachment, single or multiple small peripheral atrophic breaks and dialysis, strong vitreous and adhesions, that is an important thing, and no focal area of PVD. So that's why buckle is a first choice given option when you deal with a pediatric detachment. And for sure, either segmental buckle along with an encircling band, that's probably a choice. And these eyes do invariably well, somewhere around more than 90% success rate. So technique as far as scleral buckling concern is same as adult. Obviously, you do under general anesthesia. Cryopexy can be used for a detached retina where you're having lesions, and in attached retina lesions, we can treat with a laser to minimize the inflammation. So though SRF drainage is preferred, sometimes detachments are very shallow, long-standing, so sometimes it's difficult to drain subretinal fluid, and probably you may need repeated paracentesis to achieve a desirable buccal effect. What you need to have problem area is obvious orbit is small, narrow palpebral fissure, to sometimes difficult to accommodate the buccal. Sclera is thin, and muscles are also thin, so there is a high risk of snapping the muscle or globe perforation during passing suture, as you see here. And thick stain and capsule, and then post-operative management of amblyopia and induced myopia is an important issue when you deal with. And that's what paracentesis we need to do to achieve desirable buccal. And this was typically what you see old retinal detachment with multiple subretinal bands, but they do very well with scleral buckling surgery. And this is a post-operative picture, same eye, having a pre-surgery and post-surgery buccal effect, retina is attached, and the other eye of the patient lineated the laser to the lattice degeneration areas. So this is a previous picture what I showed in a last year in a Stickler syndrome, and you just get tempted with doing a vitrectomy in these eyes, but let me tell you, these eyes do very well with scleral buckling, holding on very well. Other eye also, we did a laser. Coming to vitrectomy part, indications would be giant tear, multiple large break, posterior breaks, old detachment with extensive subretinal proliferation and PVR, and post-scleral buckling, recurrent detachment, and of course associated congenital disorder. Invariably, they need vitrectomy along with some amount of retinotomy or retinectomy, and generally again combined with scleral buckling on encircling band, because peripheral vitreous invariably you cannot remove, so they need support. So again, basic principles are same, but what we understand here, because sclerotomy need to be anterior place, and pulmonary fissure is narrow, so your maneuverability is restricted, and generally wide angle visualization system is very, very helpful in dealing with eye. So when you look at the sclerotomy, this is a general guideline. Somewhere around up to 1 year, you can have a 2 millimeter. Up to 3 years of age, you can have 2.5 millimeter, and 3 years, you can have 3 millimeter, and go beyond 4, you can use 4 or 3.5 to 4 like adult sclerotomy. That's the general guideline, but case to case, again, you can do, if necessary, transillumination and choose location of your sclerotomy site. Smaller eyes, yes, we do have a shorter MIVS instrument, both Alcon and dark. They are come with a shorter instrument if necessary. The advantage, because they are shorter, they are stiffer, so easy maneuvering, and of course, they reduce the risk of retinal lens damage and ease approach to the anterior periphery. So this is just showing visualization using a comparative. When you use a contact lens system and wide angle system, it's the same eye. As you see, this was ROPI, but you can see the wide area covered when you use a wide angle visualization system, which is not possible, particularly when maneuverability is not there. It's better to use a contact wide angle system. So managing lens, yeah, as far as possible, knowing that age with a vision development, preferably keep the lens in place as far as possible, because that's definitely going to help for vision development. But if you decide to remove the lens, best way to remove the entire lens, no capsule left behind or rim behind, like it can act as a scaffold for your subsequent reproliferation. So coming to vitreous, typically pediatric vitreous is like a gel, more dense, very sticky. Separation of posterior hyaloid almost sometimes extremely difficult or even may not be possible, and surgeon need to have a lot of time to be spent and should be willing to have a lot of patience to deal with, because your entire success of surgery depends on how well you can induce the PVD and clean the vitreous. Cutter port observation obviously does help now with sting, so that's an idiot. So this is again just to show how difficult to peel this vitreous off, as you see here. And again, another case showing, and when a mobile retina, when you deal with difficulty, and then you have a high risk of, as you see, retina coming into port, getting caught into the port, and creating iatrogenic complications and break. There are multiple breaks, as you see here, what had happened. So you have to be careful. You can use a PFCL to stabilize posterior retina while dealing with the anterior part. So silicone oil invariably prefers the internal tamponade, and because of positioning is difficult post-operatively, and also it helps in early visual rehabilitation. But the catch here is emulsification can be very early in children, and there is a high incidence of glaucoma. Looking at a post-operative care, obviously, quite some time you cannot monitor babies. They are not cooperative. IOP cannot be checked, and you may need a repeated GA examination and post-operative period, and you need to keep parents informed accordingly. And obviously, management of amblyopia is very, very important. This is the last slide. Thank you very much for patience hearing, and I take this opportunity to invite all of you to our next Retina Summit, which the theme is retinal trauma, which is in July this year. Thank you so much. Thank you.
Thank you, Pramod, for excellent presentation and giving us everything what we need to know about issues related to pediatric retinal detachment. If there is any question for Pramod, because he has to leave, so one question, please. Yeah.
So, like, if we do only encirclage, is it okay or it's mandatory to add on with segmental in your experience?
Depends on where the lesions are.
Yes, sir.
If you have only peripheries involved and near aura somewhere, and we are not able to debulk, obviously you use encirclage. But if you have additional break, they are a little bit posterior, particularly inferior breaks, and have vitreous adherent to that, I would prefer to support segmental as well, along with encirclage. Okay. The problem sometimes is eyeball and orbit is small, and sometimes adding that segmental buckle, sometimes there is no space, and that is a difficulty sometimes. So that's why case to case you take a call.
So, like, can we place encirclage, like silicone sponge with this segmental buckle, or it has to be band only?
Preferably because easy to, you can do that, what you are saying, but easy to have a tire which covers encircling band cover over it.
No, I would suggest sponge. Thoda sa we have started less. When we are training sponge, we used to do, but sponge has a notorious this thing of having, attacking infection also.
Yeah,
Possibility of
it's
infection
erode
certainly
through, very easy to erode through
Erode
sclera,
also.
long
Erode.
term, particularly when you are dealing with the pediatric age.
Yeah. Best is to have solid silicone.
Thank you, sir.
I think quick question, please.
May I ask
Yeah,
you a quick
you can-
question? I want to know your view on the primary prophylaxis on buccal in sticker syndrome. Do you have any comments on the prophylaxis buccal?
Very rarely I do. Yes, I agree. If one eye is not doing well and already lost, and you have a lot of peripheral tractions, and you know you are going inside, you cannot do vitrectomy because you will not be able to induce PVD, and retina is still attached. Those eyes, sometime I do prophylactic buccal in the eyes, particularly FUR group, again, not only stickler, along with FUR, sometimes few cases I did. But there's a very select group of cases nowadays. Close follow-up, even though you add supporting buccal, you will need it in spite of that.
Okay, thank you very much.
Thank you.
Thank you, Pramod.